We're going to talk about the clinical applications of inhaled anesthetics and begin with the thought that inhaled anesthetics are used in more than 90% of the general anesthetics that are given in North America. They continue to be the mainstay of our practice in anesthesia. Why is that? What do they supply that nothing else supplies as well? Anybody?
Control.
Control. Say it louder.
Control.
And everybody together. Control. They supply anything else?
Breath-to-breath analysis.
Yeah, and that relates to the control that we're talking about. That we can control these anesthetics with each breath that we give.
Gives amnesia at very low doses.
It gives amnesia, so they supply a complete package. That's the second C. The first is control, the second is complete package. Both immobility and amnesia. And in fact, they supply other aspects of anesthesia as well, don't they? They can supply relaxation. They can supply some suppression of autonomic reflexes. And although imperfect, they can supply an element of analgesia.
Relatively low cost.
And that's the third C. Relatively low cost. Say, what is it that they also can supply?
Relatively low cost.
Relatively low cost. So we've got the three C's, the most important of which is control. And this is illustrated in this slide from the work of Tang and co-workers, and simply indicates for office-based anesthesia the percent of patients who moved at some point during the anesthetic experience. One group of patients was anesthetized with desfrane, and 5% of that group moved. The other group was anesthetized with propofol, and 40% of that group moved. We can't predict what concentration will inhibit movement. And that's something you want to inhibit for surgery. The surgeon lets you know in no uncertain terms when the patient moves. And you can control movement, prevent it, by using a potent inhaled anesthetic. It doesn't matter that it's desfrane. It could be sevoflurane, it could be isoflurane. The point is that with all of these anesthetics, you can obtain control. Now, we have three primary anesthetics that we deal with: sevoflurane, isoflurane, and desfrane. And let's talk about the desirable aspects of each and the disadvantages of each. If we're talking about sevoflurane, what are the desirable aspects of this anesthetic? What are the desirable aspects?
It's non-pungent, so you can use it for
Non-pungent.
inhalation induction.
Anything else?
It's low solubility.
Low solubility. Okay. And those are two very desirable aspects. Is there anything else? Non-pungent, low solubility. What about cardiorespiratory effects?
Those are, it acts as a bronchodilator, and there's no rhythmogenic effects.
No rhythmogenic effects. What about stimulation of the circulation?
It doesn't.
Okay. And also, it has a minimal effect on the ozone layer. Why is that?
No chlorine.
No chlorine. Okay. And the disadvantages are that it isn't the least soluble. We have agitation during recovery. It's a costly anesthetic, and it has the greatest degradation. What about isoflurane? What are its desirable attributes? Anybody? Yeah. What?
It's cheap.
It's cheap. It's by all odds the cheapest of the anesthetics. Okay?
It also shares some of the same qualities with sevoflurane, where it has minimal cardiovascular stimulation.
Right.
It is pungent, however, so it would not be a good choice for an inhalational induction.
Do you think you could induce anesthesia?
Well, we
with it?
saw yesterday that we could use desflurane for an induction, so you probably could if you used a combination of isoflurane with nitrous oxide at a relatively low concentration.
Right. So you'd have to stay below, say, 1.5 Mach in the delivered concentration. Okay? So we've got this low acquisition cost and a more limited cardiovascular stimulation. And we did mention that it is very resistant to degradation, both metabolism and degradation by absorbent. The problem with it is that it's got a moderate solubility. It does have the pungency that you noted. It is degraded by dry absorbance to carbon monoxide, and it has that minor effect on the ozone layer because of the chlorine atom. And what about desferrine? What are its advantages?
It's the least soluble.
It's the least soluble. Say that louder. What is it?
It's the least soluble.
Okay. Anything else?
It's the least metabolized or degraded.
So it's the least degraded. It's most resistant of all of the anesthetics to metabolism or degradation. And so we can use it at low inflow rates. We can use it down at 500 cc's per minute, which is sometimes where I go. Can't get much lower than that without returning the gases to the circuit that are drawn off for analysis. With that, though, you can go down to a closed circuit and have a very inexpensive layer anesthetic. It has minimal effect on the ozone layer because, like sevoflurane, it has no chlorine in it. And the disadvantages are that it is a pungent anesthetic at concentrations greater than MAC. It can produce transient cardiovascular stimulation at concentrations greater than MAC. Like sevoflurane, it has a high acquisition cost, which can be minimized a bit more than with sevoflurane with the use of low flow rates. And it can, like isoflurane, be degraded to carbon monoxide by dry absorbance. And the amount of degradation, the amount of carbon monoxide that can be produced, is greater at a given MAC multiple with desferrine by far than is possible with isoflurane. So those are the advantages and disadvantages that we have to keep in mind when we talk about the clinical use of these drugs.
Dr. Eger?
Yes, please.
A disadvantage that's not noted there on desflurane, if you include agitation with recovery with sevoflurane, then I would believe you'd have to include it with desflurane also.
You're right. You would have to include it, particularly for the young patient. It hasn't been studied as extensively as with sevoflurane. With sevoflurane, there seems to be a difference between it, at least, and propofol, or between it and halothane. The differences for desferrine haven't been established, but clearly it has been noted to be associated with agitation afterwards, and one would suspect it would be similar to sevoflurane, but that's still to be determined. Now, what about the young patient? We talked about agitation as one of the problems. What are the general considerations that you think of when you think of, I'm going to be anesthetizing a 3-year-old patient? What do you think of? What do you think of?
Well,
3-year-old patient come to you and
one of the things I think about is that in younger children, the MAC is usually higher than in an adult. So the concentration of the delivered anesthetic that I'll be providing has to be higher in a younger child.
Very good. What else?
Their metabolism, well, in smaller than 3 years old, say the neonates, some of the metabolism that passes through the liver in a child, both of opioids and inhalational anesthetics, may be altered based on two things. The neonates generally have less active hepatic enzymes, and two, they may still have intrahepatic shunts that will divert some blood flow from the liver to cause longer duration of action of some drugs.
And that wouldn't be a problem with 3-year-olds, would it?
No, not 3-year-olds.
Okay. What about apprehension?
Yeah, sure. Most kids after the age of like 10 months have some sort of separation anxiety. A lot of times we'll have to provide some sort of pre-medication, either oral midazolam or even oral ketamine at times, to kind of calm the child down before we take them back to the OR.
How would you propose to induce anesthesia?
Generally, I would probably use inhalational technique, pre-med with maybe half per kilo of midazolam. Take the child back to the operating room and continually talking to the child to comfort them during this whole procedure if they're still cognizant of what's going on. Use 8% sevoflurane with like 6 liters of nitrous and 3 of O2.
Mm-hmm.
Provide an inhalational induction with that, and after the child is asleep, we'll go ahead and intubate the child and then start an IV.
Okay. And you choose an inhalation induction rather than an intravenous induction?
Oh, most definitely. Kids, unless you want to hold the child down to get an IV, and I think that's just barbaric. I think it's easier just to use an inhalation procedure.
And you said you'd rather use sevoflurane than halothane. Why is that?
Well, it wasn't that I would rather use one or the other, but since we only have sevoflurane here, the problems with halothane would be the decreased cardiac function and maybe bradycardia in children, and since they're heart rate dependent for the cardiac output, that would be a bad thing.
Any other reasons to choose sevoflurane?
It's less, I don't know, pretty quick onset, and it's not very pungent, so the kids don't really fight when they breathe.
Is
it in.
halothane pungent?
Not really. I've used it in the past, but I've personally never used halothane, and I really don't know that much about its use in kids.
But as far as you know, it too is a non-pungent agent. So that
Exactly.
wouldn't differentiate it from sevoflurane.
Right.
Nonetheless, there appears to be the thought that it is a smoother anesthetic. That is, sevoflurane is a smoother anesthetic than halothane, whatever smoother means. And there are data suggesting that it may produce less postoperative nausea and vomiting. You've already indicated, as is on this slide, that it might be safer in terms of blood pressure, heart rate, certainly safer in terms of hepatotoxicity and arrhythmias. And the limitations are that it's more expensive. And there is the problem that James was talking about of potential postoperative agitation. How will you deal with the issue of postoperative agitation? How are you going to avoid that?
Sometimes you can give, well, in adults, typically you can
This
give
is a 3-year-old.
a 3-year-old still. You can use morphine at the end to sedate the child a little bit as they awake from the inhalation anesthetic.
Who would rather use fentanyl than morphine? Okay, why would you rather use fentanyl than morphine?
Well, if toward the end of the case, if the patient is spontaneously breathing, you can take small doses of fentanyl and titrate that in, and you can get a quicker, I guess, scenario of how the patient's responding to that. And it's relatively more short-lived than morphine is. So if you do overdose, then you still have time to recovery.
So it's quicker in and quicker out.
But I would disagree with that because morphine is a longer-acting drug than fentanyl, and if you titrate effectively, like 50 mics per kilo, you'll absolutely have no problems with emergence in this child, and actually the duration of their comfort will last through the PACU and probably expedite them from the PACU back to the floor. So I would disagree in using something short like fentanyl in that case.
You would have, as you say, a longer tail with the morphine than you would with the fentanyl.
Right.
But when would be the peak effect of the morphine?
Probably in like 10 minutes, 10, 12 minutes after you give it, you should see an onset in a child.
You should see the onset, but
Right.
peak effect.
It's going to be longer than that.
It's going to be much
20
longer.
minutes,
than
30
that.
minutes.
Could be 30 to 45
Right.
minutes. And do you have that kind of window? Do you have that time? You really have to anticipate a lot.
Well, it would depend on the case because generally when I provide anesthetic, I like to get the person breathing several minutes before the case is over. At that point, I'll start to titrate the morphine and be careful again with a child. It's starting with, like I said, 50 mics per kilo is not a very high dose at all, and I think that's effective. In my experience, kids have they wake very calm and comfortable with that technique.
Mm-hmm. Mm-hmm. What about the old patient? What are your concerns in the old patient? You got a concern?
Well, in general, elderly individuals have more comorbidities that you need to think about when delivering a general anesthetic. And with these comorbidities, usually they're taking multiple medications, which may affect your anesthetic technique.
Mm-hmm.
They also tend to be fairly sensitive to a lot of the drugs we use in anesthesia, particularly opioids, benzodiazepines, a lot of the depressant medications that we use. You need to usually go down on the dose, and that may show an exaggerated effect to what medicine you give.
And do they awaken smoothly, or do they awaken sometimes confused?
More confused, and specifically the ones that generally are older and have more problems seem to awaken more confused.
And what does that indicate to you in terms of the anesthetic choice?
That would indicate to me that we probably need to use anesthetics that don't linger as long, perhaps, so we can get them more to their baseline functioning earlier after the end of the procedure.
So that would indicate poorly soluble inhaled anesthetics.
Correct.
Returning to the issue of medication that you might give them, as you say, they're more sensitive, and you want to be careful because of the issue of residual effect of the drugs that you give them. For example, if you give them midazolam pre-medication, the standard 2 milligrams that many of us give to patients, the time to discharge from the PACU after a say, a desferrine nitrous oxide anesthesia, although I don't think it matters whether it's desferrine or not, in, well, this is a middle-aged patient, maybe not quite an elderly patient yet, but the minutes to PACU discharge can be increased by the premedication with midazolam in an older patient. And if you give that 2 milligrams to an older patient, you may find that the incidence of desaturation, or at least saturation is less than 94% in the holding area, goes up. And I notice that here, when you give a bit of midazolam or any medication in the holding area, you apply oxygen, and that may be a good reason for applying oxygen in such patients. What about duration of anesthesia? How does that affect our choice of anesthetic? Any comments? Any thoughts? We've discussed this before. What was the conclusion we came to then?
If you're going to have a longer surgery, you may want to use a less soluble agent so that the person awakes in a timely fashion, as opposed to waiting for 30 to 60 minutes for the anesthetic to wear off enough for them to actually awaken.
Right. So the more soluble the agent, the greater the deposition in tissue depots, and the greater the influence on the time to recovery. Yes?
I think one of the things I keep hearing repetitively here is that, you know, using an insoluble agent has a faster wake-up time, and that's probably true if you turn both agents off, isoflurane, desferrine, off at the same time. But I believe Sean mentioned yesterday, no one's going to wait to the last minute to turn isoflurane off after like a 5-hour case. And so typically if you turn that off like the other day I did a case, turned it off 35 minutes early, ran nitrous at the end of the case, and I extubated about 2 seconds before they pulled down the drapes. I wouldn't have done that with, you know, if I had desferrine, I obviously would have left it running longer. So
Why?
I think, why? Because it's a shorter time off. I mean, the clearance.
Why not do the same thing with desferrine that you do with isoflurane? Why not get the faster recovery with both the agents, but proportionately more with desferrine than with isoflurane?
Well, I think one of the concerns, again, is cost. If I'm going to run an agent, let's say, for 3 hours, desferrine versus isoflurane, it's going to be cheaper for me to run 3 hours of isoflurane versus desferrine at the same flow. So why not just use isoflurane, knowing that I have to turn it off earlier and still get it, my wake-up times are still within a minute or two after the surgeons are finished.
You've changed the point now. You've changed the point from one of rapidity of recovery to one of cost.
Clinically, I'm talking about in terms of recovery clinically in the OR. Not if we're doing an experiment in the lab, we just run isoflurane versus
let's
desferrine
talk
and turn it
about
off.
just clinically. If you turn the desferrine down, aren't you going to get a more rapid recovery?
Yes, if I turn it off at the same time versus isoflurane at the same time.
Sure.
But
And again, you're going to get a more rapid recovery with desferrine than with isoflurane. You'll shorten the recovery for both of them, but you get a more rapid recovery with desferrine. Now, if you have given isoflurane for 5 hours or 10 hours, do you think that turning it off for 30 minutes will get rid of the isoflurane?
Well, yesterday I did a case, and a 76-year-old woman turned it off 35 minutes before. The case lasted 4 hours, and again, she woke up right on time, 2 minutes after.
Right on time. And how awake was she?
She was wide awake, able to talk to Dr. Ligish and tell him that she was doing fine.
So you can do pretty well. How low a concentration of isoflurane were you using throughout the case?
Oh, pretty low, like about 0.6, 0.7. With a BIS monitor on, her BIS was like 42, 43.
So you minimized the concentration of isoflurane, and in fact we're relying on nitrous oxide.
Right.
Is nitrous oxide a poorly soluble anesthetic?
Very, very insoluble.
Very poorly soluble. So you were, in fact, going along with the argument of relying more on a poorly soluble anesthetic.
True.
But in this case, nitrous oxide rather than desferrine. This comparison is for sevoflurane versus desferrine. It's for, again, studies in volunteers who are anesthetized for either 2 hours or 4 hours or 8 hours, on one occasion with desferrine and another occasion with sevoflurane. And the slide shows you the minutes to respond to command after anesthesia with one as opposed to another of these agents. And the point of this slide is to show you that with the more soluble agent, the slope, that is the effective duration, is greater than with the less soluble anesthetic. So recovery is more rapid with a less soluble anesthetic and less influenced by duration of anesthesia. We've talked earlier about problems presented by the obese patient. What are the problems presented by the obese patient? What has the obese patient got that we haven't got? Nobody in here is really obese.
Large fat stores.
They've got large fat stores. Okay, both of the depot fats and of the fat adjacent to highly perfused tissues, that fourth compartment. So we've got greater storage capacity for anesthetics. And again, that indicates the use of a poorly soluble anesthetic. What are the other problems in association with obesity? What else concerns you?
They may be enzyme-induced.
They may be enzyme-induced. Again, you want to be careful about anesthetics that are highly metabolized, particularly if that metabolism might lead to toxicity.
You have decreased respiratory reserve,
You have decreased respiratory reserve. Why is that?
primarily because of decreased functional residual capacity, decreased chest wall compliance,
Okay.
primarily.
Have you ever anesthetized an obese patient and find that the saturation disappeared?
Yeah, I work here at Wake Forest, so I do it on a regular basis.
That's a real problem. A real problem. So you want to be sure when you're anesthetizing the patient that you've got the lungs full of oxygen and you have the capability of applying positive pressure so that you don't have this collapse and desaturation. And the same thing applies on recovery from anesthesia. You want the patient to be awake so that they can maintain their FRC before you remove the endotracheal tube. And you want that to happen quickly. You'd also like the patient to be mobile. You'd rather have someone who weighs 130 kilograms move themselves from the operating table to the gurney, wouldn't you? And that was studied by Juven, who established a mobility score. That's unique. I don't think I've seen anyone who's established a mobility score for patients. And the mobility score was 4 equals a patient who moves without assistant, and 0 is a patient who is immobile and unconscious. And Juven divided his patients prospectively into 3 patient groups. One was given desflurane, another isoflurane, and another was given propofol. Those who were given the less soluble anesthetic had a greater ability to move from the operating table to the gurney. What about the patients who have renal and hepatic failure? What are your concerns there?
Prolongation of effect of your opioids or other drugs that you give in addition to your inhalational agents.
So fixed drugs might be of concern to you in those cases. And you'd want to use an inhaled anesthetic, which you know you can get rid of.
Mm-hmm.
So it's a reason to choose an inhaled anesthetic. On the other hand, the toxic effects of the inhaled anesthetics might be greater in those patients, mightn't they? They might be more vulnerable to noxious effects. So you'd want to keep that in mind, although there's precious little evidence that that is in fact the case. I think you'd want to use the poorly soluble inhaled anesthetics that would allow you this in and out without any reliance on metabolism. It would be a particular indication if you needed muscle relaxants, because the liver and the kidney are important to the elimination of muscle relaxants. And the use of a poorly soluble agent, which would allow you to get relaxation, as much relaxation as you would need with or without the muscle relaxants, would allow you an element of safety that might not be possible with fixed agents alone. What about the patient with a difficult airway? One where you're concerned about the potential for loss of the airway in the course of induction. How do you manage this? How are you going to deal with such a patient? How do you deal with such a patient? So we got a patient with, say, a fixed cervical spine and an inability to open their mouth very widely. What are you going to do with that patient?
Well, first of all, I'd examine the patient, see what kind of range of motion they have, what kind of Mallampati score they have, whether or not I feel that an awake fiber optic intubation will be the best choice for this patient due to the immobility of the cervical spine, or whether or not I feel laryngoscopy would be a possibility.
What if you said to yourself, I think I might be able to do it, but I'm not sure.
Well, in that setting, then I would proceed with a wake fiber optic. I
Okay.
don't think we have the choice to risk whether or not we can.
Okay. What about an inhalation induction with something like sevoflurane?
It definitely could be a possibility with a poorly soluble agent. It's not routinely a first agent of choice here because we have short-acting IV agents that we can use if we were going to try a DL of the patient. And there's always a possibility of aspiration with inhalation induction.
Okay. And if you were to use an inhalation induction, how would you go about it?
Well,
Which agent would you use?
Would probably use a poorly soluble agent for the same concerns that we have when using IV agents. We'd want to use a short-acting paralytic. If we were going to go down that route, we'd use a short-acting IV agent so that we would allow the patient to return back to spontaneous ventilation if we would have in trouble placing endotracheal tube.
So you want to be able to back out if you get into trouble?
Sure.
Okay. And you'd use desferrine, wouldn't you?
Well, it does provide advantages, and from what I've seen in this video, inhalation induction had looked a lot, it worked a lot better than I originally would thought also. So under a 1 MAC, you've clearly shown that it's a possibility, but due to my own experience, I probably would use sevoflurane.
Okay.
Just because I have more experience with that in inhalation inductions.
I'd use sevoflurane too. Let's see how Dr. Olympio did it.
Quinn, we have today a patient whose airway is a concern to us. It hurts her neck when she moves it. She has a pinched nerve in the neck, and today we'd like to do an inhalation induction.
Okay.
What are your plans after that?
Well, we're going to initially induce with nitrous oxide and sevoflurane, and then as the patient gets deeper under anesthesia, we're going to bolus with remifentanil and gradually take over ventilations, making sure it's possible to hand ventilate the patient.
Right, so we don't want to burn any bridges
Exactly,
going into
and
this.
if there's ever a problem, we can turn the remifentanil off and we'll immediately have hopefully a return of spontaneous respiration.
Okay, and this avoids doing this procedure awake, is that correct?
And that is correct.
Okay, why don't we begin?
Okay. Ms. Humphrey, we're going to let you breathe some oxygen through the mask here. It's going to be a little bit of a tight fit there. Just take a few deep breaths, and as you breathe in and out, we're going to increase the amount of gas and you get sleepier and sleepier, okay?
We're on 50% nitrous, and I'm going to begin to increase the sevoflurane, and we're at 2% on the dial. You'll see spontaneous ventilation. Why don't you ask our patient how she's doing with that?
Doing okay, Ms. Humphrey? We're doing a good job with the breathing there.
And Quinn, I'm continuing to go up on the dial. I see here a good respiratory rate, good tidal volume.
Right. We're starting to see some alveolar sevoflurane.
And we have end-tidal CO2, and we're on 5 and 5 of nitrous and oxygen.
Okay.
How's our patient doing?
Ms. Humphrey, can you hear me? Okay, you're doing real well. You're getting sleepier and sleepier. She's somnolent, but still arousable to voice.
Okay, why don't you ask her to take a deeper breath?
Ms. Humphrey, take a deep breath in and out. That's perfect. Keep breathing in and out there, Ms. Humphrey. Can you hear me? Okay, the patient is now not responsive to voice and has a slight lid reflex.
All right, if we look up here, we still have spontaneous ventilation at a rate of roughly 10 to 14. Our patient is asleep. We've maintained a spontaneous airway. Now, we could continue to do this, but it's our objective to test the airway. Is that correct?
That's correct.
And then to deepen the anesthetic with remifentanil. Why don't we start to take over control of ventilation
Okay.
and see how easily that can be performed. And right now I'm beginning to lower the sevoflurane concentration.
Okay, I'm now assisting the patient. And we're not having any problems with obstruction.
So we're at now 2% sevoflurane on the dial, and I'm going to begin the remifentanil bolus.
Okay. I'm now doing the majority of the breathing for the patient.
All right, Quinn, the remifentanil bolus at 1 mic per kilo has started.
Okay.
The fact that we're using the remifentanil allows us to lower the end tidal sevoflurane. Now, if we were to have any response during the fiber optic endoscopy, would we feel comfortable giving vecuronium to paralyze the patient?
At this point, I would be comfortable with that. I'm moving air without any difficulty.
And alternatively, we could use a short-acting muscle relaxant, such as succinylcholine. Is that right?
That's correct.
Okay. Well, I'll tell you what, since this airway is so easy to manage and we're not having any difficulty, why don't we administer the vecuronium now? And doing so will enable us to lower the concentration of the volatile anesthetic. But we certainly have an option of going one way or the other.
That's correct.
Now we have adequate blood pressure. Of course, we are regulating the concentration of sevoflurane. I had been on a dial of 1%. I'm going to go back to 3% and noticing our end tidal of 0.9. We should get a rapid rise in that. But I'm confident that the remifentanil will also assist our intubation. I'm noticing our end tidal oxygen concentration is 76%. We're inspiring roughly 90% oxygen. Our saturation is 99%. And I think it's safe for us to proceed with the fiber optic. Ben? And Ben, are we helping you or hurting?
I've got a view close.
Good.
Drive it in.
Uh-huh. Now, meanwhile, Quinn, our remifentanil infusion is running.
I see we have a minimal hemodynamic response, if any at all.
Uh-huh.
Blood pressure 131/72, heart rate is 73.
And our saturation's 99. So we have lots of time, there's no urgency involved, and we're able to intermittently ventilate as necessary. Now I'm going to help Ben with this endotracheal tube insertion. Go ahead, Ben, you can slide that in. Very nice. That looks to be deep enough.
Yeah, right up there.
Do you still see the carina?
Yes, I do. I'm coming
Good.
out of the scope.
Very nice. Cuff is going up.
Got it. Okay.
And don't breathe yet. Let's listen to breath sounds.
You got several things there for the price of one. Several aspects of the technique for intubation were accomplished in that single video. You had a question?
Yes, regarding the use of an inhalational induction for suspected difficult airway, what about the risk of the patient who would have laryngospasm and then would not be exchanging air and would not be able to blow off the inhalational agent, so there you've lost your way to back out?
What would you do? You burned a bridge there, didn't you?
It seems like you could, yeah.
Okay.
And
so that certainly is why you wouldn't use desferrine for this sort of approach. You'd use sevoflurane. But let's say you did use sevoflurane and you did get laryngospasm, which is possible with sevoflurane. What would you do then?
Well, I'd first try positive pressure ventilation.
Okay, and that failed?
Then I'd have to move to a fast-acting muscle relaxant.
You would, that's right. And you're prepared, aren't you, to give succinylcholine?
Yes.
Okay. You would burn yet another bridge, though, wouldn't you?
Yes.
Okay.
I guess my point with that, though, is if we do an awake fiber optic intubation, we're much less likely to get to that point with good topical anesthesia.
Absolutely. What's the downside of the awake fiber optic intubation?
It's uncomfortable and can be disturbing to the patient.
Would you like to have an awake fiber optic intubation?
I would not like to have it, but
I'd rather die. Well, that may be a little extreme, but I don't want anyone manipulating my airway while I'm awake. So that's a real downside to the awake intubation. It is uncomfortable, and for some patients it's very distressing. And we can mitigate that with drugs such as midazolam and opioids. But then we again run a risk, don't we? We burn the bridges a little bit with the midazolam.
There is
and with
risk
the
there
opioid.
too. Mm-hmm.
So there's nothing that's going to be perfect.
No.
Nothing's going to be perfect. And this is an alternative approach to the intubation of the difficult airway, one that provides a bit more comfort to the patient, but it entails a bit more danger. And you have to be aware of that. Now let's go on to anesthetic considerations related to specific operations. Begin with airway and thoracic surgery. We've already covered the problem that we may get into in airway surgery where we may have a compromised airway. But if we consider just airway and thoracic surgery, what are the problems that we have to deal with in such surgery? We're competing with who?
Surgeons.
We're competing with the surgeons. The surgeons also want access to the airway. And the surgeons in thoracic surgery may do what to the lungs?
Deflate.
They may deflate them. So we've got to be concerned about ventilation perfusion abnormalities. There's often a need to sustain the airway until the patient is awake. And again, to me, that indicates the use of poorly soluble agents, desflurane, sevoflurane. Yes, you can use other agents, but I think you have an advantage if you use the less soluble agents. Similar problems exist for ear, nose, and throat surgery. Again, competition for the airway. Again, a need often to awaken the subject quickly at the end because you've got to leave the endotracheal tube in place in order to assure that the airway remains patent to the end of the anesthesia. And again, I think it indicates the use of the less soluble agents. What about eye surgery? Do we have problems with eye surgery that we have to consider? Or is that just a very ordinary kind of surgery? What's the problem with eye surgery? First of all, what's the age of the patient? They're often older patients. So we have the problems of elderly patients. And if we open the eye, what problem do we have there? What problem do we have?
Worry about extrusion of ocular contents. You also have to worry about anytime you're manipulating the eye, ocular cardiac reflex, bradycardia.
And bradycardia. What do you do about that?
You can pre-treat. It's also a self-deprecating reflex, and with time, as long as it's not hemodynamically significant, it will attenuate itself after time. So if it's problematic, you can treat with atropine or a longer-acting antimuscarinic. Have the surgeon hold what they're doing until the patient recovers, or again, if it's not significant, it will attenuate with time.
Can you do a block?
You could, but that also has risk.
What are the risks?
And you've got risk of precipitating the reflex by placing the block. You also have the possibility of essentially a very high spinal by injecting the anesthetic in the location that you are.
You know, that's an interesting possibility. I've never seen it happen. Have you seen it?
No.
Never seen it happen, but it's certainly theoretically possible. How much atropine would you give?
0.4.
0.4. Would you give it all at once?
Mm-hmm.
Do you think you might get profound bradycardia with 0.4 of atropine?
I'm sure you could probably have a paradoxical reflex.
Yes, you do. Okay. All right, those are concerns. Any other concerns about eye surgery, retinal surgery?
I think upon emergence, coughing or, as I say, bucking on the tube can also increase intraocular pressure at the end. So sometimes you may want to extubate the patient a little deeper than normal, so that you reduce the risk of them coughing at the end of the case.
Certainly, deeply anesthetizing the patient to the very end will minimize that, and that's a very good point. So what anesthetic are you going to choose?
I think any of them would be fine. I'd probably use, I could use sevoflurane or desflurane.
Okay. Again, if you're going to maintain anesthesia at a deep level to the end of
Desflurane, probably.
Then the concern that was expressed about delaying recovery becomes even more important. Do you all give a little bubble in the eye ever? Why do you do that? What's the bubble in the eye for?
It's
to tamponade or prevent further retinal bleeding.
Okay, and to hold the
Hold the retina in
down
place, right?
in place. And what's the danger?
Expansion by nitrous.
So you wouldn't use nitrous oxide in those cases?
Dr. Olympio, I've called you into the room because they're about to inject gas into the eye now.
What anesthetic are you using?
Well, we're using volatile agents, but we're not using any nitrous.
Why not?
Well, nitrous would increase the pressure in the air-filled cavity, and that would decrease blood flow to the eye.
Well, I think you're absolutely right. It's a good decision you made.
We have a whole list of surgeries and the indications and contraindications or difficulties associated with each. We have heart surgery, and we've talked about heart surgery and the concerns that we have in the context of intrathoracic surgery. The additional concern with heart surgery is that there's often compromised blood flow to the heart. And we've talked about the effects of potent inhaled agents on the heart as protective agents, all of them, the isoflurane, the sevoflurane, and the desflurane. There isn't much to choose among those anesthetics for that purpose. One of the concerns that is added in open heart surgery, particularly coronary artery surgery, where we rely heavily on opioids, is the need to provide amnesia. So we want to be sure that we choose an anesthetic other than nitrous oxide, one that will give us good amnesia for the total course of the procedure. What about neurosurgery? What are our concerns there? What do you want to achieve? What would you like to achieve during neurosurgery, where we're working on the brain?
You want to create optimal conditions for the surgeon as far as the expansion of the brain.
How are you going to do that?
Well, you could give something like mannitol to decrease the size of the brain.
Okay. And what about in your choice of anesthetic?
You'd probably go with isoflurane.
Okay. Why would you choose isoflurane?
It's better protectant against cerebral ischemia. It's gonna it's not going to increase the cerebral blood flow as much as the others.
As desflurane or sevoflurane?
Right.
And it provides better protection?
Right.
Do you know of any evidence that say it provides better protection than sevoflurane?
No.
Or desflurane?
No.
Okay. So we're not quite sure about that, but it may indeed produce less of a change in cerebral blood flow. How else can you manage the issue of cerebral blood flow?
By hyperventilating the patient.
Okay.
To decrease the CO2 level, you're going to decrease the blood flow.
You'll decrease blood flow.
Right.
What else can you do?
I don't know.
Okay. How about the concentration of anesthetic? Is that going to influence cerebral blood flow? If you give 1.5 Mac of isoflurane, what's that going to do to cerebral blood flow if you maintain the blood pressure?
It's going to increase.
It'll increase it.
Right.
So you might be cautious in how much anesthetic you gave. You might keep your anesthetic down below 1 Mac or 3/4 of a Mac. How would you do that and not have the patient move? Because that's another thing you really don't want to have happen with a neurosurgical
You
case.
can incorporate nitrous oxide.
Okay. What does that do to cerebral blood flow?
It can slightly increase, but not as much as your agent.
Why does nitrous oxide sometimes cause an even greater increase? What does it do to metabolic rate, cerebral metabolic rate?
It can increase.
Increase or not change,
right.
As opposed to isoflurane, which might do what to cerebral metabolic rate?
It's not going to change it.
Oh, it would decrease it.
Decrease it, right.
It will decrease
right.
metabolic rate. So nitrous oxide has some undesirable aspects in neurosurgery. So if you don't want to use nitrous oxide, what are you going to substitute? You want to give only maybe 1/2 or 3/4 of a Mac of isoflurane. So what's going to be the difference? We talked about how do you decrease Mac. What would you give? In the
You
IV?
could use some opioids.
You use some opioids.
Right.
Do you do that commonly when you give anesthesia for neurosurgery?
Yes.
Indeed we do.
Yes.
Indeed we do. Okay, now the procedure is over, and the surgeon is interested in what at the end of the procedure? What does the surgeon want to do? She's done this marvelous neurosurgical procedure, and she thinks the patient's okay, but she's not sure.
assess their level of consciousness.
She'd like to assess that as soon as possible.
Right.
One of the reasons why some people like to use less soluble agents. If you're going to do neurosurgery, another concern is seizure activity, isn't it? Would that animate your choice of anesthetic?
Yes.
Okay. What anesthetic is of concern there?
Enflurane and possibly sevoflurane.
Right. How about orthopedic surgery? What are our concerns there? Orthopedic surgery?
Blood loss.
Blood loss. Blood loss. That's one of the biggest ones. So how are you going to manage blood loss?
Depending on the type of surgery, we may use induced hypotension.
Okay. What type of surgery are you thinking of?
A big spinal surgery.
Okay. Spine surgery, that's a good one. What else?
I'll take some help from my colleagues.
You do total hip replacements here?
Yes.
And do you do repeat total hip replacements?
Yes.
What's the blood loss in those?
Large.
Large, okay. Can be a liter or so. That's again where you might want to use induced hypotension or a regional anesthesia in combination with an inhaled anesthetic. And if you're going to use induced hypotension that's induced by the inhaled anesthetic, you're going to have to go to deeper levels. And that may delay your awakening. And again, you may want to choose a poorly soluble agent to achieve hypotension, because that won't delay your awakening nearly as much as it would with a moderately soluble agent. Outpatient anesthesia. Is that important to us?
Yes.
And if so, why?
It's increasing.
It's increasing. What fraction of the anesthetics in North America are done as outpatient or office-based anesthesia?
70%.
Exactly so, 60 to 70%. So we've got a lot of anesthetics that are given that way. Brief, but often demanding a profound level of anesthesia, but very brief. We demand that recovery be rapid. Why?
Turnover.
Because what?
Because of the turnover, because they're doing so many surgeries and most of the surgeries are so brief, so you want to get the patient in and out and get them through the PACU.
So you want to get them in and out rapidly. You want a rapid transit through the perioperative process. And it's clearly a field for poorly soluble, potent inhaled anesthetics. Beverly Phillip, I think, uses nothing but sevoflurane for her outpatient anesthesia. And desflurane is a clear choice as well. What about upper abdominal surgery? What are our problems there? Let's see, who haven't we called on lately? What's upper abdominal surgery? What are our problems? Yes, please.
The pressure on the diaphragm and difficulty
Right.
expanding the lungs.
Right. What else?
Well, you don't want to use nitrous oxide in the abdomen because you
Some
could expand
people
the lung
don't.
space.
Surgeons are now demanding that we not use nitrous oxide. Okay, so no nitrous oxide, pressure on the diaphragm.
Mm-hmm.
What else?
Potential for regurgitation.
Yes. You're going to need relaxation for these procedures?
I would, yes.
Yes, indeed. It's going to have to be profound, too, isn't it? Profound relaxation. Is there going to be a problem with postoperative analgesia?
Well, yes, they'll hurt if you don't give them enough narcotics.
Is there any operation that produces greater pain postoperatively than upper abdominal surgery?
I guess a sternotomy would.
Sternotomy might, yeah. But that comes pretty high on the list, doesn't it?
Yes.
Upper abdominal surgery. So there are a lot of problems with upper abdominal surgery. How are you going to achieve the profound muscle relaxation?
With muscle relaxants,
Okay.
try to maintain just one twitch.
Try to maintain one twitch. Why do you want to maintain one twitch?
Well, if you have one twitch, you know you can reverse the patient at the end of the procedure.
Okay, fair enough. And are you going to use muscle relaxants with a little propofol, or what? How are you going to give the anesthesia?
It really depends on what type of abdominal surgery you're doing. I'm thinking laparoscopic right now, but I assume you mean one that's actually
Well, I mean an open
an
procedure.
open.
Yeah.
Well, you're going to have to use a potent inhaled anesthetic to maintain.
I don't know
your-
that you have to, but it's certainly desirable.
Yeah.
Okay. Let's go on to monitoring depth of anesthesia. If you're using a potent inhaled anesthetic, how do you monitor depth of anesthesia?
You look at their alveolar concentration.
Yeah, it's very simple. But it's more difficult to do if you're using a combination of anesthetics. If you're using a combined technique with a minimum of potent inhaled agent. And in that case, we may want to look at processed EEG signals, such as the mid-latency auditory evoked potential. What's the mid-latency auditory evoked potential? What is that? Mid-latency, so a middle latency, middle delay, auditory evoked potential. What is it?
A signal that we can detect in the brain after the auditory nerve has been stimulated.
Okay, how do you stimulate the auditory nerve?
With some type of device that makes a click sound in the ear.
So you make a click in the ear, and then you look at the resulting EEG, and you analyze that a number of times, maybe 100 or 500 or 1,000 times. And you see what waves occur. You measure their latency, that is, the delay between the click and the time the wave appears. And you measure the amplitude of the wave, both its negative amplitude and its positive amplitude. So the positive amplitude, labeled P here, decreases with increasing anesthesia. So it correlates inversely with a potent inhaled anesthetic concentration. That's true of desflurane, it's true of sevoflurane, it's true of isoflurane. And you can see that at 1 Mach you may still have a wave, but it's markedly depressed. It is supposedly a measure of awareness or consciousness. That is, once you've gone beyond a certain depression, say 50% depression, you've achieved unawareness or unconsciousness. It isn't very widely used, though. It requires a considerable amount of computing power, which is available, and it's easily disturbed by noise. And there isn't a commercial entity that's available, at least at present, that will give you this output and allow you a simple analysis. What is the one that is commercially available and allows us a simple analysis? The BIS monitor. Okay. And what does BIS stand for?
Bispectral index.
Bispectral index. Okay. What does it measure?
It takes raw data from an EEG, and it, through bispectral analysis, it converts it into a quantitative value, and it gives you a number between 0 and 100. The lower the number, the deeper the level of sedation or hypnosis. The higher the number, the more awake the patient is.
Right. And indeed, it used to be a bispectral index, where it looked at the correlation between waves within the EEG, but it is no longer that, and it's not really known what it is. It's a proprietary device that, as you say, gives you a number between 0 and 100 that allows you an estimate of what? Is it depth of anesthesia?
Sedation, basically.
It's basically sedation. So we really don't measure depth of anesthesia with a BIS index. We measure sedation, or maybe consciousness or awareness, and we say what number is a good number?
We try to keep the number below 60. Once you go above 60, it's thought that the patient may have higher intraoperative awareness, or definitely above 70.
Definitely above 70, they may have awareness. And what's the limitation of the BIS monitor, besides that it isn't really a depth monitor, it's simply an awareness monitor?
Well, one limitation is there's a lag time. There's about I think it's a 15-second lag time, so that the number that you're actually seeing on the monitor correlates to the state 15 seconds ago.
So there's a delay, okay. Any other limitations?
You need to have a steady state of stimulation. If you're changing amounts of stimulation, the BIS number will not be as helpful.
Well, maybe it's reflecting a level of awareness that's altered by the stimulation.
Yes, I get to explain that further. If you have a BIS number that you're comfortable with, for example, while the surgery team is prepping and there's very little stimulation, if you have that, if you maintain the patient at that number and then they all of a sudden go to incision, that level of anesthesia you had for prep time may not be deep enough for the increased stimulation that they had.
Okay. Okay. We had a question here?
The BIS monitor also has a limitation that it just measures cortical values. It has no way to detect spinal reflexes, so even it doesn't predict who's going to move or not with incision. They may have an adequate depth of sedation, but then it doesn't predict who's going to move right after incision.
Right. It was never, no, I shouldn't say that. It is not intended to predict movement, and it doesn't pretend to, so that it isn't fair to criticize it for that, but it's certainly true, and that's a limitation that we have to take into account. Any other limitation? Yes?
Well, two things. It can be interfered with by cautery. I know now that they've developed a new BIS monitor that has less interference, but if you have a lot of cautery, it can be ineffective, and it's not effective with drugs like ketamine.
So there's certain drugs where you can't use it with ketamine. Doesn't measure ketamine. What happens with ketamine?
Well, you could have amnesia, but you'll still be reading a high number on your BIS monitor.
So it won't reduce the BIS number. Okay. Tracy, did you have a
I
comment?
was going to mention the drugs as well. I don't think a substitution for an equal MAC fraction with nitrous affects the BIS as much.
It doesn't affect it at all, does it? Nitrous or xenon. So if you're interested in giving xenon, don't use the BIS monitor. It doesn't work at all. Okay. How are we going to deal with nausea and vomiting? Changing the subject now. For example, this is a very important topic because it's one of the great concerns of patients. It's one of the primary concerns of patients. Who is going to be nauseated? Who's going to be nauseated?
Young women usually.
Young women like you, all right? Who else is going to be nauseated?
Also, those patients with a history of previous surgeries with post-op nausea, vomiting, or high rates or increased rate of having post-op nausea, vomiting with future surgeries.
So listen to your patient, and in that preoperative interview, you find out whether they've got this history, okay?
It also depends on the type of procedure that's performed, and maybe that may be tied into the population that's having that procedure, but typically thyroid surgeries and gynecologic procedures also have a much higher incidence
of nausea and vomiting. Right. Plastic procedures. Michael?
It also depends highly on our anesthetic choices that we make during our anesthesia, whether we, even the amounts of oxygen that we deliver, the amounts of fluid that we give, the choices between narcotic and inhaled anesthetics that we pick, things like that.
Those are all important. So youth, gender, specific procedures, the drugs that we give, and even relaxant antagonism. What relaxant antagonists are we concerned about? Neostigmine, and particularly doses above 2.5, 3 milligrams. So if these cause it, how do you avoid it? Well, avoid anesthetizing young women. It's certainly one way to do it. And avoid plastic procedures, and don't give any of those drugs that cause nausea and vomiting, and certainly don't reverse the effect of the relaxant. Indeed, although that was said somewhat facetiously, those are techniques that you need to consider if you really want to avoid nausea and vomiting. So if you want to avoid nausea and vomiting, you don't give an opioid. I avoid thiopentol. And you don't give nitrous oxide. And you can substitute for each of those. You don't have to give opioids. You don't have to give thiopentol. You don't have to give nitrous oxide. Certainly you can avoid relaxant antagonism if you deal with relaxation another way. And you can always give high oxygen concentrations. One thing that many people aren't aware of is that if you give high amounts of fluid, a lot of lactated ringers, that too will minimize nausea and vomiting. And you can use multiple antiemetics, including propofol, but including droperidol and dexamethasone and the serotonin blocking drugs. All of those together can minimize your nausea and vomiting. The oxygen, I find a particularly interesting the high oxygen, I find a particularly interesting way to decrease nausea. This is in Gall's work published last year in Anesthesia and Analgesia. It indicates that if you give isoflurane in oxygen and nitrogen, not nitrous oxide, in nitrogen, and the oxygen concentration is 30%, the incidence of postoperative nausea and vomiting for 24 hours after anesthesia is 35%. But if you change the oxygen concentration, decrease the nitrogen to 20%, oxygen 80%, the incidence of nausea and vomiting falls by half. And that's as effective, that change in oxygen concentration is as effective as giving 4 milligrams of ondansetron. So it's an effective therapy, a preventative, for postoperative nausea and vomiting. Going back to the multifaceted nature of postoperative nausea and vomiting, that probably multiple receptors are important to the precipitation of postoperative nausea and vomiting. If that is true, then you want to use multiple antiemetic drugs that block different receptors. So you might want to use droperidol or metoclopramide and ondansetron and promethazine or dexamethasone. And indeed, with the use of multiple antiemetics, you can reduce nausea and vomiting to the level that you see with an anesthetic that we know has actually antiemetic effects, which would be propofol.